Hi everyone, thank you for being here to view our presentation on Lewy Body Dementia. My name is Hunter and I will be performing the voiceover for this presentation. Lewy Body Dementia is a chronic degenerative disease typically affecting those between the ages of 50 and 85 and is usually associated with abnormal aggregates of protein. We will go into more depth as we move into the presentation, so let's continue. So for this presentation, we will be covering these main aspects: Lewy body dementia as a chronic disease, the descriptive epidemiology of Lewy body dementia, the characteristics and signs and symptoms of Lewy body dementia. We will explain how Lewy body dementia is a complex disease. We will discuss current rehabilitation strategies for those suffering from Lewy body dementia, as well as go into depth of a rehabilitation strategy. In this case, we will be determining the effectiveness of music therapy on dementia using an article our group has found, including the PICO analysis of music therapy and the overall critique and advantages and limitations of the research publication. So a chronic disease is defined as a disease that is long-term, develops slowly over time, is controlled but is unlikely to be cured, and reduces daily functioning. Dementia falls into these categories as it causes a decline in cognitive functioning for individuals. Currently, there is no cure for Lewy body dementia. However, there are treatments such as music therapy, which can control the symptoms and behavioral aspects associated with dementia. Dementia, along with Lewy body dementia, reduces daily functioning for individuals suffering from the disease and interferes with social and occupational functioning. For instance, in 2017, the Public Health Agency of Canada found that 54% of seniors with dementia reported having impaired mobility, and 37% reported moderate to severe pain and discomfort. Thus, looking at the data outlined above, Lewy body dementia constitutes as a chronic disease. The World Health Organization estimates that about 47.5 million people are living with dementia around the world. More than 402,000 individuals are living with dementia in Canada, and approximately 3 to 10% of those individuals are suffering from Lewy body dementia. Additionally, approximately 2/3 of people living with dementia in Canada are women. As there is a growing aging population, the amount of Canadians living with dementia is expected to increase, and by 2031, the total annual healthcare costs for Canadians is expected to double, from 8.3 billion to 16.6 billion. The number of individuals with dementia are going to increase, as will the healthcare costs. For dementia, there is an incidence of 14.3 new cases per 1,000 individuals and a prevalence of 7.1 per 1,000 individuals, the majority being women, and the prevalence and incidence of this disease increases with age. From 2004 to 2014, the prevalence in Canada increased by 21.2% and will only continue to increase over the next few years. Also, mortality rates are 4 times higher for individuals who suffer from dementia. This figure compares all-cause mortality rates of seniors with dementia and all-cause mortality rates of seniors without dementia from 2003 to 2014. Since 2003, dementia-related mortality rates have decreased slowly over time. However, all-cause mortality rates with dementia in seniors was 4 times higher than seniors without dementia. Symptoms of Lewy body dementia greatly vary from patient to patient, and the degree in which the disease affects a person is different in every individual case. Lewy body dementia symptoms are quite often divided into 3 stages in order to organize their progression across the individual's life. So we have the early stage, the middle stage, and the late stage that we will talk about in future slides. In the early stages of disease, Lewy body dementia patients experience delusions and hallucinations, as well as difficulty sleeping in the REM stage of sleep. They will also experience early signs of difficulties in movement, such as the occurrence of slow movement and unsteadiness from lack of balance. As stated on the left image, the initial symptoms of Lewy body dementia starts with memory or cognitive disorders such as limited attention span and impairment in problem-solving skills. Then it goes on to movement disorders and neuropsychiatric symptoms such as behavioral problems and difficulties with mental activities. During the middle stages of the disease, Lewy body dementia starts to take a serious toll on the patient. During this stage, patients begin to struggle to form sentences and recount memories from the past. Hallucinations and delusions heighten, leaving the patient very confused and paranoid of what is going on around him or her. During this stage, the individual begins walking around with a strong shuffling gait due to rigid muscles and begins to have strong tremors that mimic Parkinson's disease. These movement challenges make the chances of falls very high, and the patients are in need of constant care. In the later stages of Lewy body dementia, muscle rigidity and tremors worsen to the point of having the inability to move. Patients begin to struggle to speak as well as diminished mechanisms of the autonomic nervous system, including regulating blood pressure, heart rate, and respiratory rate, as well as continence and other bodily functions. During this later stage, the patient's memory loss worsens. They lose the ability to speak, and depression and agitation begin to set in. Lewy body dementia patients are often considered to have the neurological symptoms that mimic Alzheimer's disease and physical symptoms that mimic Parkinson's disease. Lewy body dementia is complex based on the three concepts of complexity that we have discussed in lecture. The first criteria is that more than one disease is present through comorbidity, polypathology, etc. In Lewy body dementia, studies have shown that mental and behavioral disorders such as depression and anxiety are quite prevalent, along with migraines, stroke or cerebral infarctions, nervous system and respiratory system dysfunctions, and diseases of the eye. The second criterion is the use of healthcare resources. Those with dementia in general spend an additional 2.5 hours in the ER department compared to seniors who don't have dementia. Hospitalization rates for seniors with dementia are 65% higher than those who don't have dementia and are twice as likely to stay longer in the hospital, which can cause a strain on our healthcare resources. The last criterion for dictating Lewy body dementia as a complex disease are the psychosocial, environmental, and lifestyle factors. Dementia patients typically have limited independence due to their diminished cognitive functions, leading to an increased burden on caregivers and families who have to care for them. The cognitive function of a patient with dementia can also interfere with the patient living their daily life and carrying out simple tasks such as cooking, cleaning, and other activities of daily living. Many dementia patients must be put into long-term care facilities to be taken care of because they no longer can take care of themselves. By being in these places, many patients experience poor quality of life. Some studies have shown that to improve the quality of life of these individuals, some long-term care facilities are introducing animals into therapy sessions, specifically the involvement of dogs. It is shown that the overall mood, behavior, and quality of life of individuals with dementia who resided in long-term care facilities significantly improved. During therapy sessions of these individuals, many studies have shown the improved behavior of individuals in relation to decreased anxiety levels, depressive states, and decreased agitation. Some patients were able to recall memories from interacting with the animals also. Overall, the contribution of animal therapy provides a substantial improvement in the patient's behavior. However, there are a few risks in animal therapy, like teaching the patient who themselves may not be able to care for themselves how to properly interact with these animals, as there is a safety concern for these animals, not to mention the lengthy process in which to train these animals and the amount of resources needed to care for the animals as well. The mirror sign is seen in patients with dementia or other neurodegenerative diseases. It occurs when the person with dementia fails to recognize themselves in the mirror. Patients that experience mirror sign also show levels of psychotic episodes and paranoia. A study was conducted on a patient that experienced mirror sign and referred to her reflection in the mirror as the woman living next door. She began associating her reflection as an intruder who wanted to steal her things and followed her around. In an effort to diminish her paranoia and delusional thoughts, staff members decided to put a frame over the bathroom mirror to just show her from the neck up because she was able to respond normally with smaller mirrors, which allowed herself to perform normal activities like brushing her teeth and combing her hair in handheld mirrors. They tried to mimic the handheld mirrors in the mirrors in her bedroom. By doing this, the patient's behavior significantly improved. Her mood improved and her delusional behavior slowly stopped as well. This form of therapy is good for patients who experience mirror sign. However, each patient experiences mirror sign differently, so introducing this method to other patients may not necessarily be as efficient. Dementia is a degenerative disease seen in older adults that result in disruptive behaviors along with other symptoms. To ease the effects of dementia, prescribed medication is given, but it can cause many side effects like dry mouth, agitation, etc. Other ways of treating people with dementia to ease their symptoms is using a form of therapy, in this case, music therapy. Studies have shown that music therapy is known to reduce the effects of anxiety and depression, which is common in people with dementia. With music therapy, there are a few ways in which it can be done, either in individual sessions or group style therapy. It can be either active therapy or passive therapy. Active therapy is when individuals partake in the singing or playing instruments and making music, while passive therapy is when patients listen to music and analyze the meaning of the music, which usually happens during treatment. When it comes to reducing the anxiety and depression level of individuals, studies have shown that levels seem to drop and music therapy is shown to improve mood. Music therapy has a greater effect on anxiety levels and depression levels, but in some patients, cognitive function also improved, allowing them to recall certain memories. Music therapy is a great way in which patients with dementia can improve their symptoms related to dementia. Many studies show that it is quite effective in relieving symptoms. It does not cause negative side effects like dementia with medication and is a great alternative for non-pharmacological treatment. A research publication that our group found to be in line with dementia patient rehabilitation is the effects of music on symptoms of dementia. This article consists of a meta-analysis of randomized control trials, including dementia patients, and the effectiveness of music therapy on disruptive behaviors associated with dementia, such as anxiety, depression, and diminished cognitive functioning and agitation. We decided to choose music therapy as our main rehabilitation strategy, as it is a non-pharmacological treatment to Lewy body dementia that is a fairly new method which could be relatively inexpensive and accessible for patients suffering with dementia. A meta-analysis is a research design that generates a pool of studies to come to conclusions of a proposed research topic. In this study, the use of randomized control trials were included and featured older adults within 65 to 87 years of age, diagnosed with any type of dementia, so mild, moderate, or severe, as listed in the Diagnostic and Statistical Manual of Mental Disorders 4. The studies also included an experimental and control group where music therapy was not provided, and music therapy was divided into individual and group therapies as well as active and passive music therapy. In this study, data was obtained from databases such as PubMed, Medline, Cochrane Library, CINAHL, Scopus, and PsycInfo, and was gathered over a 15-year span. The aims of the study were to examine the overall efficacy of music therapy on disruptive behaviors, anxiety levels, depressive moods, and cognitive functioning, and to determine which of the groups I have just discussed, which one had more significant effects. According to the slide, I've provided a PICO analysis of the article, which gives a relative understanding of the research question that the study aims to give its readers. So the population pertaining to this study are patients suffering from dementia. The intervention is the application of active musical therapy, which is actually engaging in the music by the use of instruments or singing, or passive musical therapy, or just listening to the music. The comparison the article is trying to establish are those patients who have not been exposed to music therapy compared to patients who have been exposed. Lastly, on the PICO analysis, we have the outcomes, which is that music therapy will provide dementia patients with decreased symptoms such as anxiety, depression, diminished cognitive functioning, and agitation. Along the lines of symptom alleviation, effect sizes for the sample collection of the study were all negative, except for cognitive functioning, which only showed a moderate improvement. However, the other categories strongly implied that musical therapy significantly reduced overall disruptive behaviors, anxiety levels, and depressive mood. However, the higher quality studies showed larger effect sizes than the average quality studies. The studies showed that individual therapy showed a larger effect on disruptive behaviors, anxiety, depression, and cognitive functioning compared to group therapy, and that 2 sessions a week consisted of a larger effect than weekly sessions. For those suffering with mild to moderate dementia, music therapy deemed to be more effective at improving disruptive behaviors and depression, whilst moderate to severe dementia patients had improved anxiety levels and cognitive functioning. So here I've provided an overall critique of the article with advantages and limitations pertaining to the study. So for the advantages, meta-analyses have to be similar enough to be accepted. Therefore, across all studies, there must be a level of similarity between them, giving the researchers accurate information. Meta-analyses are best for disseminating across large populations, and in evidence-based medicine, since many studies will prove the research is indeed significant, which can be applied to in practice. Publication bias can be evident in meta-analyses as the researchers could only accept the most significant reports of studies, which can overestimate the effect of the intervention. However, based on this study, funnel plots and Egger's regression analysis showed that a p-value of over 0.05 indicated no publication bias in this study. This is the first meta-analysis of randomized controlled trials relevant to music therapy and dementia that has been conducted over the past 15 years. Therefore, this information could be useful in forming public policies and to implementing this form of rehabilitation strategy into practice. Lastly, meta-analyses can reduce the need for repeated studies, which can be costly and time-consuming. And for limitations for the study, they are as follow. So based on the study, it is really unknown whether the studies were based on a geographical or demographic level. Therefore, we do not know where most of the studies have been derived from, and if other factors, such as socioeconomic status, could skew the results of music therapy intervention. The average age of participants ranged from 65 to 87 years. Therefore, those with earlier forms of dementia or those older than 87 or even younger than 65 might have different results pertaining to music therapy. The effect size could be inconsistent due to the range of 15 years of chosen studies. The study only consisted of 10 approved studies, therefore the statistical effect of the study may be inadequate. And lastly, the higher quality studies showed larger effect sizes than the average quality studies, which could skew the overall effect size of the meta-analysis. Therefore, for future recommendations on the effects of music therapy on dementia patients, it would be helpful to know where the studies came from in terms of geographical area, and we think that having a less strict inclusion criteria would allow for a larger number of studies to become retrieved in the research process and give a better generalization on a larger scale. Although cognitive function was only moderately improved by music therapy, other disruptive behaviors, anxiety, and depressive moods showed a significant improvement. Therefore, music therapy could be incorporated into group homes and other establishments to encourage positive relief of these symptoms that are commonly experienced by dementia patients. And here are references for this presentation. On behalf of my group and myself, I would like to thank you all for listening to this presentation, and I hope you find these pieces of information helpful for future reference. Thank you.